move my hands. Maybe that'll.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Everyone, imagine making the hardest choice of your life, to lose a leg just to end the debilitating pain, only to wake up and realize the pain is still there. It's the agony of phantom limb pain. And because it's Limb Loss or Limb Difference Awareness Month, we are revealing a breakthrough that I think could finally silence those ghost signals. Joining us are Dr. John Eidt, Chief of Vascular Surgery at Baylor in Dallas, and David Veino, CEO of Neuros Medical, with a device that is literally switching off the pain. Welcome to the Heart of Innovation. I'm Kym McNicholas with Dr. John Phillips. I'm excited. This could really help a lot of your patients, right, Dr. John?
Yeah, I mean, unfortunately, there I think are too many amputations that occur in this country. The last time I looked, it was about 185,000, I think, a year, and the majority of them are from vascular complications, but then the traumatic ones, and then to a lesser degree, cancer. So we need to be better at preventing these amputations. But for folks that do have a major amputation or undergo a major amputation, this phantom limb pain is real, and the folks are going to get us up to date on the prevalence of it and stuff. But I just read this morning that upwards of 50% of people can have chronic phantom limb pain after 6 months, and that's got to be really debilitating and disheartening, because a lot of times some folks will come in and their leg is just not, from a vascular standpoint, not salvageable, and they want the pain to go away, and so you do the amputation, but then they get the phantom limb pain, so it's like just amplifies kind of the salt in the wound, so to speak. So this should be a great show. Looking forward to the conversation.
And you remember legendary Harlem Globetrotter Larry Shorty Coleman, who spoke on Capitol Hill, but he had one leg amputated, and still 5 years later, he can't get rid of the phantom pain. And in fact, he was approached by his doctor about this technology. And so he's really excited to hear what Neuros Medical's David Veino has to say about this particular technology and whether it's something that could be right for him. But 5 years later, to still have this debilitating phantom pain. And coming up, Dr. John, I really do want to get to Dr. Eidt about what is this phantom pain? Why does it occur? I mean, and what ways are currently being used to get a handle on it. But first, I think let's go to a moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
Well, of course, I have to find a quote from someone who's had an amputation, someone who's been successful, and walks, etc. In fact, this is name's Jessica Long. She is one of America's most decorated Paralympic swimmers. She was a double amputee at 18 months, honestly. So she's lived her entire life basically without legs. But despite that, won like 30 plus medals, almost 20 were gold. So a pretty inspirational person. And she has this quote that I think is just, it's kind of like a duh kind of quote, like, yeah, I am different, but that doesn't make me I can still succeed. And so she said, you didn't have to tell a girl with no legs, that was her, that she was different, she was missing half her body. But she says, I really had incredible parents who taught me that, God has always had a special plan for me. And, you look at someone like that who now has won 30 gold medals and is a true success. And so, listening to folks that have had amputations, how difficult it is to get walking again, and then to swim or whatever, to do a sport is even more difficult. So helping with phantom limb pain has got to be a lifesaver for some of these people.
And I love the quote that you said that, you got to let go of the past. You got to accept where you are, because Kevin Thomas Morgan, who's a PAD patient, that poor circulation in the legs, that's really what we're talking about when it comes to the amputations here that Neuros Medical is addressing, and that Dr. Eidt will talk about the phantom pain in relation to. But um, you know, Kevin Thomas Morgan has a book. It's a PAD training manual that's available on Amazon. And he spends the first chapter talking about handling the grief of diagnosis, the grief of any loss of capacity or your experience or whatever it might be, and letting go of the past and literally moving forward. But I imagine with these patients that have this debilitating phantom pain, that's really difficult to do, to forget about the past. And so this could really help them let go and move forward to persevere with PAD.
Yeah, it sounds like it. So we should jump into this because I'm excited to hear about the device and how it helps people. And it sounds like there's an unmet need for sure, and some positive things on the horizon for folks with phantom limb pain.
Should we get with Dr. Eidt? You deal with these patients all the time. You deal with these amputations. Talk about the phantom pain. What is this phantom pain? Because patients think that when they have the amputation, they're going to get rid of this debilitating pain. Some do, some don't, because some seem to get this continuing pain. Can you talk about that for us?
Yeah, Kym, I think that's a really good point. And it probably is true that for a third of patients who have a major amputation, particularly those with vascular disease, and probably a third of them do have a very effective treatment. We don't like to think of an amputation necessarily as a failure of therapy. In fact, for many patients, it's very effective. It gets rid of pain and it restores their ability to carry on with their life, admittedly with a disability, but with the ability to move forward. But for another third, and maybe even more than 50%, that therapeutic procedure, the amputation, leaves them with either persistent residual limb pain, that is, you can actually have pain in the stump itself, or so-called phantom pain, that is the perception of the residual limb. So they can say, I can feel my foot, I can feel my toes tingling, I can feel burning in my foot. And that occurs, we think, predominantly because the nerve, the major nerve in the leg is called the sciatic nerve. And it's an amazing nerve. It's as big as your little finger. It's a giant nerve that comes down the back of your leg, just like a fiber optic cable. And it has thousands of little nerves within that bundle. And when you have an amputation, those nerve fibers are looking for something to do. And they're reaching out to try to find their other half, the other half of the nerve that's now missing. And so those little nerve fibers often form a little network called a neuroma, which is basically these nerve fibers that don't have a purpose, and they form a little bundle of nerve tissue that can be quite painful. And it can affect the use of a prosthetic because it creates pressure, and it can cause spontaneous pain like phantom pain and residual limb pain. So it's a challenge for surgeons because we're mainly focused on getting the wound to heal. And yet, once we get the wound to heal, many of these patients function in some ways as orphans with really out of medical home.
And coming up next, right here on the Heart of Innovation on KDOW, we're going to hear about a new solution, a breakthrough in technology from Neuros Medical that could be helping to silence those ghost signals. So stay with us, don't go away. So explain this to me just so I can be clear. It almost sounded at first like you have a certain, maybe there are two types of the phantom pain. There's like but is it really phantom pain you're solving? Or because the phantom pain, that's the perception of the pain that maybe there is nothing there, and that, or those that's still driven by the nerves, the neuromas that are like right there in the ends. So there really are nerves that are firing. But then there's the other, that there were nerves that were literally left behind, the residuals. I'm a little confused.
Well, it's a little bit of one answer. That is, the ultimately all pain is ultimately received in the brain. Ultimately, pain is received in the brain. That is, if you don't have a sensor, you don't have the pain. But when you do have an amputation, you can have pain that is a result of the wound itself, the healing wound. That is, it hurts. And it can have residual pain in the stump, in your amputation itself. But you may also have perceived pain from the part of the limb that is no longer in existence. That is in your foot or in your toes or downstream. And that's usually what we call phantom pain, because it's not emanating directly from the tissue that's still residual, that's still there. And
30 seconds.
Both of these can be quite disabling.
Okay. I don't know, Dr. John, if you want to start there and have him kind of give the Cliff Notes version of that, or where you want to go. But
sure, we should get David in, right? Kind of how I'm interested to know how you got plugged into this company as well. Okay, yeah, we can figure something out. Just wing it.
Yeah.
Banner to sign up
Just want to
today.
make sure we transition.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. We're continuing our conversation about phantom limb pain and kind of some new technology out there to help treat these folks. So John, as we were discussing kind of during the break, you got the sciatic nerve that now is looking for something to do. So number one, are there patients that are at an increased risk to develop more phantom limb pain than other? And number two, we'll get to the Altius device at some point here really quickly, but prior to that, how are we treating that pain for these folks? Is it opioids? Is it physical therapy?
Yeah, that's a great question. The reality is that many of these patients wind up being, to some degree, sort of medical orphans. That is, the surgeons have gotten a healed wound. Patients have often been through some period of rehabilitation, either an inpatient or outpatient rehabilitation. But after a few months, they're often left on their own to sort of try to navigate this situation. And they often wind up going to pain clinics or to physical medicine doctors or to other primary care people. And they're often frustrated because there really isn't a sort of a home that focuses on this. And I think that's one of the things that I learned in participating with the clinical trial of the Altius device a few years ago. This is an enormous sort of problem that I was certainly unaware of as a vascular surgeon who's done this for 40 years. To think that there are 2 to 3 million people with major lower extremity amputations in the United States currently, and we expect that to double over the next few years as the baby boom, bolus of patients comes through. So we have millions of people, and many of whom have significant post-amputation pain that is in reality being ineffectively treated. So many of these patients do wind up with narcotic addictions, or at least narcotic use, and they have a heck of a time trying to figure out a way to restore their activity, to get back to life and get control of their pain. So I think it really is an iceberg of a problem where we just barely see the tip of the problem. And there's a great opportunity for treating a large number of people who've had a significant disability.
Do a lot of these patients that have had amputations go back to you and say, I have a lot of this residual pain? Or do they just simply go to their primary care now sends them to the pain clinic? Because I know for Larry Shorty Coleman, he's 5 years later still going to the pain clinic.
Yeah, well, I think that's exactly what happens. The other place they go is they go back to the poor prosthetists. These guys, this is a whole community who've really dedicated their lives to creating these bioprosthetics, these devices that allow people to walk. And the patients go back to them because they're their primary medical contact. And we actually have found, and David's been a real leader in this, is identifying the prosthetist as the most common touch point for these patients to seek care. So we've really tried to develop an allegiance with the prosthetist to say, hey, you can, they try to do different things like modifying the prosthetic, do padding and change the shape. and do different things to sort of create a different way to contact the limb. But also they are in some ways, they become the primary caregiver. So we think they're the critical piece of this puzzle, to know that there's an alternative to narcotics and pain medicine, and to get
I've heard that
prosthetic community.
So David, welcome to
Yeah.
the show. Tell us about the Altius device, how you got involved, and kind of where it stands right now from a clinical aspect.
Yeah, thank you. So, yeah, spent about half my career, about 30 years in medical device, half of that in coronary and peripheral interventions. Working to save a lot of limbs from amputation. And unfortunately, we couldn't save all of them. So I think the thought process is, what happens to these patients should they get an amputation? What happens to their care? Where do they go? What's their life like? So I had the opportunity to join this organization 8 years ago, pick up the device when it was in its very early infancy development, ran it through a PMA clinical trial, 180 patient trial, over about a 4.5 year period. Dr. Eidt was a huge part of that, as well as other vascular surgeons. And the results were tremendous. You saw a significant level of acute pain reduction for these patients, long-term pain reduction, and two of probably the most important things: reduction in opioid dependency. 42% stopped taking opioids altogether as a result of the utilization of this device, and a significant increase in quality of life. So I think we demonstrated the ability to relieve pain and restore life. And as Dr. Eidt said, there's 2.5 to 3 million patients in the US today that are lower limb amputees. Up to 80% of them will have chronic post-amputation pain as per the literature. 185,000 major lower limb amputations every year. We do not need any additional lower limb amputations. Treat the patients we have, get them back into the care of the vascular surgeon so they can do comprehensive vascular care on the remaining limb, and just the overall health of the individual.
Right, because some of these patients that end up with that residual limb pain, they go in and do they get additional amputations? Do they just go higher? Is that what happens?
They have several amputations. So in our clinical trial, most patients were 8 years post their initial amputation, with them having at least 2 to 3 amputations during that period of time, and lived with significant pain that entire time with very few treatment options. So you're talking about a large population that is really a large unmet need, searching for a solution that most physicians don't have a treatment option for. You kind of see that a lot with situations like this. So finally, we've got a solution to be able to apply to the appropriate patient population.
Yeah, and I was on your website, and so I wanted to just share with the audience a testimonial of a patient who it sounds like, so frustrated with this he was contemplating suicide, I think. So, I mean, this is a huge problem. So tell us about the device. What does it do? Who qualifies for it? And how does that process work?
Yeah, if you're a major lower limb amputee, so you could be above the knee or below the knee amputee, if you're a good surgical candidate, which is really going to be determined by the surgeon, if you failed conventional therapy, which insurance makes patients do all the time to get another advanced therapy, if they fail conventional therapy, mainly a drug regimen, and qualify for that, then they come in for a very simple diagnostic test. We have the physicians inject their sciatic nerve with lidocaine. And if the lidocaine block produces a 50% level of pain reduction, they qualify for the implant. The implant is then done under general anesthesia, maybe 45 minutes to an hour, skin to skin, and the patient's out the same day.
So, John,
coming up next, right here on the Heart of Innovation, we're going to find out exactly where this is implanted, because I know online, if you go to the Facebook groups, you can see all the chatter about the complications with spinal implants for pain. So where is this device being implanted, and how are they mitigating risks for complications? That's next, right here on the Heart of Innovation on KDOW. Don't go away. Sorry, John.
You got me, Kym. I know. So I saw 2 minutes. I was like, damn. I had some time.
I saw 2 minutes and I was trying to count down. I think we still had About a minute
Are we
15
over?
left, but
Yeah.
um,
We might have been over anyway. So the follow-up question I'd like to ask you guys is, you know, how do you quantify in an objective fashion a 50% reduction in pain after the lidocaine? Because I would imagine there are people who are like, hey, I'm going to come in for this thing. I'm going to tell them I had pain reduction so I get this implant. Is that even a concern, or am I thinking out la la land?
I mean, I'll tell you about our perspective, and then I'd like Dr. Eidt to tell us his. I think, in the trial, we did a blinded saline versus lidocaine screen.
Okay.
So we
Okay.
did a really good job in the trial to really try to weed out as many of those placebo responders. We see, as a result of the implants that we've done commercially today and how effective that therapy has been for our patients, we can tell that they really had a 50% level of pain reduction. So it's an NRS scale, numerical rating scale, where they will ask them, what's your pain before the injection? They will give the injection, and 30 minutes to an hour post that injection, they will ask them what their pain
Okay.
is.
And
If
then the
there's a
patient,
50% reduction.
they don't, do they know that you guys are looking for a certain percentage reduction, or is it just, hey, just tell us how you feel? Okay, that makes sense.
Right.
Okay.
Yep.
So I guess coming back then, does it make sense to just walk us through the process?
yeah,
Is that cool? Okay.
Yeah.
that'd be great. Because then I've been working with the NHS and the Royal College of Vascular Surgery on all of their research projects and recruiting patients. And one of the trials is called the placement trial. They're testing whether a paraneural catheter next to the main nerve during surgery can actually reduce the need for morphine and lower the incidence of phantom limb pain. And so they just deliver a local anesthetic through the catheter for 5 days post-surgery. And they're now comparing the patients who receive this treatment to those who just receive standard pain management post-procedure. And so far, they have about 650 participants, and they're finding great success in the early days. If they manage the pain in the early days, that long term, they're starting to see better results. So I don't know if you've seen anything like that, if you've ever done anything like that,
Kym,
Dr. Eidt.
there's quite a bit of interest. Again, this whole pain management thing is a big black box where
30
we
seconds.
don't know a lot about it.
Okay, we could get into it actually, maybe in the fourth segment, but we'll get into this procedure in this one. And have you done a bunch of these cases, Dr. Eidt?
A bunch, I wouldn't say a bunch. I've done a few. It's not not an operation we do by the thousands. So I think, again, there were 25 sites in the clinical trial to get 180 patients. So it's not I've done probably about 15 or
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. So, Dr. Eidt, explain to the audience. So let's say I'm a patient. I come in, I've had an amputation, and I've got the phantom limb pain. You do the lidocaine injection, I get a 50% reduction, so it looks like I might be a candidate. So this device is a nerve stimulation system, right, to some degree. So talk to me as you would a patient that say, hey, I think you might be a candidate here. Let's move forward.
So what I try to do is, well, first of all, I want to make sure that they have a pain that's likely to respond to the device, because there are other explanations for pain. Limb pain is either musculoskeletal, neurologic, or circulatory. If you have residual ischemic pain, it's not likely that we can reasonably treat that with an electrical device. So one of my jobs is to make sure that the stump is actually not ischemic, doesn't have enough blood supply. Because if it doesn't have enough blood supply, then that's not going to be an effective treatment. Similarly, if they have an orthopedic explanation, like a bone spur or some kind of residual osteomyelitis or infection, probably we want to treat those alternative treatments. But if we get down to what is fundamentally a neurologic pain, and we think that's mostly mediated through these neuromas or the sort of failure of the nerve to have any function, then then we go to the test injection. Once the test injection's done, the conversation I have is, can I harm you with this procedure? We have general anesthesia. Every time you get on a plane, you usually land where you end up where you intend to land. But occasionally, general anesthesia is not good for you. So I'm very square with patients and say, you will undergo a general anesthetic. You have the risks associated with general anesthesia. We can't really do it under a local anesthetic. I tell them we worry about infection. If you get a synthetic device infected, it more or less has to come out. So we're very picky about our sterility and the whole infectious disease thing. Because again, if we get an infection, we pretty much lost the game. Bleeding is not a common complication, but it is obviously a complication of surgery. And then the fourth thing is this device really going to be effective in your case? We know that on average in the clinical trial, patients experience a 30% reduction in pain at about 30 minutes after it's turned on. And then again, about a 50% reduction by 2 hours. So it turns out, and David can explain this more in detail, the device, when you turn it on, doesn't stay on 24 hours a day. It runs for 30 minutes when you tell it to turn on. But there's a residual benefit of the device even after it turns off. And again, the idea is we're interrupting this pain cycle. Whatever this is that's causing your pain, your brain to perceive pain, we're trying to interrupt that cycle. And over time, it's amazing. You see decreased pain over months and years, decreased narcotic use over months and years, and actually even decrease of the need to turn the device on and off over time as this pain cycle seems to be interrupted consistently.
So do you foresee a time when this device can actually be removed, or is this something that's permanent? How do you deal with battery life and all that kind of stuff?
David, I'll let you hit the battery life.
Yeah, so the FDA, obviously makes us do a lot of testing. And so per our testing for the FDA, it's a 10-year battery life. But I will tell you, patients that have been in our pilot study that are out 16 years are still using their same device because it's an on-demand use, as Dr. Eidt talked about. It's not on all the time. They use it as needed, when needed.
So the device itself you're wrapping it around the sciatic nerve. Is that correct?
That's correct.
And tricking it basically. So is there opportunities to use this in other nerves, other places, or is it always going to be for patients that have had a major amputation?
It's a platform technology that we believe wherever we can put a cuff electrode around a nerve, we think we can do some different treatments. So additional studies are being discussed as we speak, and innovations for our device in other areas. The technology is unique and it blocks the nerve signal from sending a pain signal to the central nervous system. So we don't trick the nerve, we just block its ability to function. So that's the real difference between our technology and previous spinal cord stimulator technologies.
Right, because that's,
John, I didn't mean to step on you, but this device, because it takes a fair amount of charge, a lot of current to actually penetrate a big nerve like a sciatic nerve, this device has to be recharged, unlike a pacemaker, for instance, that you would never recharge. I think, David, people often recharge this once a week or on a relatively frequent basis.
Correct.
Okay.
How do you recharge it? So talk us through, what is it like as a patient?
Like a Tesla.
So you do the procedure, and then what are the take-home instructions?
Well, basically, they come to the hospital. We have to, one of the keys to this thing is we have to agree with them of where we're going to put the pulse generator, because they have to be able to get to it with a kind of remote control through the skin. And we'll identify with the patient, agree, we're going to place this in a location on their abdomen. Unlike, a lot of the spinal stimulators, they'll put on their back or in a kind of a remote location, but you really, it's not functional with this device because they need to be able to activate it to turn it on and off, and they need to be able to charge it. So we have typically placed this device somewhere in the abdomen, and you have to agree with the patient where it's not going to rub on where they have a belt and the kind of activities that they undertake. So that's part of what the pre-op planning is. Then we go to an operating room, and then we actually, it's kind of an awkward operation because we have to get to the back of the leg and get to the front of the abdomen in the same operation. So we usually position people actually on their side, although we have done one patient recently where we did bilateral amputation simultaneously, in which case we literally had to turn the patient over. After implanting the electrodes, we then turned her over and hooked her up to a single generator with wires from both legs going to the same generator. But typically we would have one generator going to one leg, and we place that up on the abdomen.
I'm sure that there are some warnings and maybe some lifestyle modifications that may come along with having something implanted in your abdomen area. We're going to find out what those are next on KDOW on the Heart of Innovation. Don't go away. Yeah, I'm just
Kym,
just like, you know, you get
that trial you were talking about in England is kind of part of what's called preemptive anesthesia. And there have been other strategies like that. For instance, give a person a spinal anesthetic for 24 hours before you do the amputation, so they go to the operating room without any pain at all. Some people think that is, if you go to sleep with severe pain, you're more likely to wake up with severe pain.
Yeah.
And that's a little bit the concept of either local anesthetic administration to the sciatic nerve perioperatively or postoperatively, or just completely eliminating their pain before they get to surgery. But again,
so can we talk about just some of those other what currently, even cryotherapy, things like that? But I can mention, you know, the placement trial again, and you know, during the actual show, and you can talk about some of this, and then also why this is something that's still more of a breakthrough for this type of thing.
The other thing we might get to is that there are some techniques to give, as we said earlier, the nerve's looking for something to do. There are techniques where people have tried to hook those residual nerve fibers up to muscles. So-called targeted muscle reinnervation. These are really typically plastic surgery, neurosurgery, microvascular kinds of techniques where you actually implant the nerves back into muscle fibers so that they do have a function and they're less likely to form neuroma. These are techniques, though, that are very uncommon. If you looked at all the patients who have amputations in the United States, these high-level techniques are only available probably to less than 5%. These are very experimental front edge types of treatments, but there clearly are probably better ways to do amputations. For the most part, amputations today are the same as they were done in 1860.
Yeah. So that's interesting, Lo. I mean, like, again, we've been doing amputations for, you know, ever, but yet it's, I guess, David and John, like, why is it taking so long for us to come up with treatment options for these patients?
Because it's so hard to treat. I think if you look at all the different treatment regimens, whether it's a lidocaine injection, great, but it's toxic to the nerve. Opioids, nobody wants to prescribe them, nobody wants to use them. Spinal cord stimulators don't really work. So when you've got something as difficult as phantom pain and residual, so 90% of the patients in our trial had both phantom and residual limb pain. Difficult to treat. There's never a problem until there's a solution. Right? Mm-hmm. Now you can apply this solution to, wow, look at this problem we now have on our hands. So I love the fact that other companies and other technologies and other clinical trials are being done, because that just elevates the need for these patients to be treated. And it wasn't until we brought our technology to the market that people really said, wow, there's a real clinical utility of a device that can really treat these patients both acutely and long-term.
And what
Dr.
percentage
John,
of
we're gonna have a lot to repeat. This is really good.
Yeah, we got a lot of meat on the bone. What percentage of patients actually qualify for this? You know, so of the people that have phantom limb pain, like, how many people can get this procedure percentage-wise? Do you know?
I would say out of the population, I will say it's very conservative. We think there's about 60% of the population we think are the right candidates for the study. So out of the total population today, we think our addressable market is about 1 million patients.
Okay.
We think there's a portion that are easily treated by other modalities. There's others that are not good surgical candidates, but we think there's about 1 million patients.
And then I guess we didn't really talk about this, is it's currently clinically available for patients, correct?
Correct. It is
FDA
FDA approved and on the market.
approved, and insurance, I'm assuming, covers it
Both
if
Medicare and commercial payers are covering the device.
gotcha. And I see on your backdrop you got a guy looking like he's gonna run into the ocean. Can you wear so this device, and I think this was one of the concerns, where you
30 seconds.
the electrode or the device, can you still work out?
It's all implantable. So once it's healed, there's no
issues.
restriction. Yeah.
Yeah, we want you to, as a matter of fact, in the trial, over 50% improvement in ambulation on their prosthetics, right? So we want people to move.
Okay. Yeah.
Absolutely. Go work out, go do your thing, go live your life.
Gotcha.
Hospitalized with injuries. This is SM.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for hanging out. So, we've talked about a lot here today, and I think what was really important that was just said during the break, at least in my opinion, was, people who get the device, you want them to exercise, you want them to walk, because if you look at the statistics, about half of people with a major amputation never achieve complete independence walking again, okay? And it gets worse if it's above the knee, right? And it's worse if the folks are older. And so I guess walk us through the expectations a patient should have after they get this device and everything heals and it's all good and you can charge it when you need to. I mean, do they have to go through physical therapy again? Is there a protocol or something, or is it just, hey, get out there and go?
And are there any limitations in terms of protecting that device? Like no contact sports?
No football.
I think that's a fair one. I think that's a fair point. This is very similar in terms of the size of the device. It's basically like a pacemaker, or you remember, at least most of our patients remember what a Zippo lighter looked like, those little silver lighters. It's about that size. And for most people who are not quite as skinny as I am, it's actually it's not a very noticeable mass under the skin of your abdomen. Obviously, you don't want it rubbing on your belt and other places, but it's not an obtrusive device. It's in a location that really shouldn't interfere with normal activities. So we want people, if they can, get back to work. We want them to be able to get out. And more importantly, as you point out, we want them to be able to put a prosthesis on and get out of the house. Unfortunately, and certainly when you look at the big three causes of major amputations, that is cancer, sarcomas, which unfortunately often occur in younger people, and trauma, that occurs, it's quite commonly the younger patient. And then the vascular patients tend to be older patients. Unfortunately, particularly for the vascular patients, the likelihood of using a prosthetic outside the house any significant number of hours a week is way less than 50%. In other words, it's a minority of patients. Now, some of that is because of balance issues or other cardiopulmonary limitations there. When you're walking on a prosthetic, it's a little bit like walking on stilts. You have to balance. It takes more energy to do it. And in fact, they estimate 40% more sort of cardiac output you need to walk with a single prosthetic. So a lot of patients just don't have that cardiopulmonary reserve. But with time, they can develop it. So yeah, some of these patients may be eligible to get back into rehab. Some of them have potentially burned up some of their rehab insurance time, so they may not. But if they can get rid of the pain and they can get their prosthetic fitted effectively, most of these people have the resilience and the knowledge to get back moving if you can just take that impediment of pain away. And that's really where we are focused with this device.
So I'm wondering, if this is something that could ultimately be part of an amputation procedure implanted at the time of, because I know in the UK, the NHS has a study that's focusing on mitigating the amputation pain. It's called the placement trial, and it's where they're testing placing a tiny catheter next to the main nerve during surgery. And they think that that actually would reduce the need for morphine and lower the incidence of the phantom leg pain. And they're seeing some really good results. So they put this anesthetic or whatever in for 5 days post procedure. Right there while they're in the hospital. And they say it's giving them good long-term results as well. If you hit the pain at the head, what do you think?
Yeah, I think there are a number of strategies. As I said before, I've done this for 40 years. I didn't have a clue how severe a problem this was. Well, this really was, that the number of patients with severe post-amputation pain is a significant problem. And we were just unaware of it.
Yeah.
We get the wound to heal, but these patients are gone. They're not back in our offices. So they're kind of lost to follow-up, as we say.
And so David, like, how do you build out the sales force? Because, it's like you got to get to these folks early, because the statistics, as I recall, if you're not walking a year after your amputation, I mean, yeah, you can have pain, but I mean, the whole point is to walk again. So you've got to figure out how to get to guys that do these procedures. And I'm not a surgeon, but I do a ton of endo work. But yeah, we still have some patients that get amputations. And so, you've got to build out a sales force and get folks. We got to say hi to Paulie T, of course. So we go back, and you got a good team, right? But so how do you get them plugged into physicians, and where do you start actually?
Yeah, it's pretty easy. I mean, you start with the centers that have the majority of amputations. So we're lucky, as everybody knows, to have enough data that shows us which institutions, which physicians are doing the majority of amputations. You look at any geographical area and you can really understand prevalence, right, and incidence of amputations in geographical areas. Marry those with the clinical sites, marry those with physicians, and then bring in the prosthetist, which is the number one. And they're not a healthcare provider, they're a vendor, but they are the most important partner to the vascular surgeons and to the amputee community, is they're the ones that are in charge of putting the limb on these patients. They need patients that are not on opioids. They need patients that are not in pain. So how do we help them get these patients pain-free so we can restore their quality of life and get on their amputation? So we target PM&R physicians, those that are diagnosing phantom limb pain, and all the other specialties, to build an ecosystem around these centers to ensure that we can get to these patients as quickly as we can, to provide education, and really an opportunity for them to understand that there are treatment options available to them should they want to pursue them. That is the biggest thing for us.
And coming up next, right here on the Heart of Innovation, we'll have closing thoughts from both Dr. Eidt and David Veino. So stay with us right here on the Heart of Innovation on KDOW. Don't go away. I'm curious if it affects the, I was thinking about, putting that cup around the nerve and controlling. Does that affect the mobility of the patient? Because I'm looking behind you at the patient with the prosthetic, and nerves play an important role, right? In movement, I would imagine.
Yeah, no problem at all. I mean, all the patients that we have seen in the clinical trial and even the commercial patients that we've implanted since we've been on the market, we haven't had any issues with the cuff electrode or the device impeding any type of mobility whatsoever. In fact, one of the things we didn't measure in the trial, which I wish we would, and we probably will in the next study, is the reduction in BMI. We saw a lot of patients who dropped a lot of weight in the trial. And I think the biomarkers and some of the other things we need to do. One out of University of Arkansas, walking marathon distances about a year after they had the device implanted. And so dramatic changes in the physical makeup of some of these people because they were actually ambulating again.
Our producer, Josh, brings up a really good point. We should mention insurance coverage. Is it covered by insurance? Is there any resistance as there is with so many? I mean, what are the parameters by which insurance won't give you any sort of pre-authorization? Heck.
Yeah, we'll cover that. And I think we're in a really good position. We're lucky to have the coverage that we do today, but as new technologies come to the market, we always are looking for ways to improve that, and we're doing just that.
There was a question in the chat, Kym, on bathing and swimming. That's perfectly good. we want them, any activity is fine because it's all implanted. There's no residual device that's exposed. So they can definitely get wet. They can get in the water. They can swim. They can do whatever they want.
That's really good.
Now, is there any
How widespread is this something that, I mean, if people are listening to this show and especially watching online, I mean, do you have these in areas that are easily reachable across the US? Is it available globally?
It's not globally yet. It's major metro centers, and I would call it Texas to New Jersey to Florida, right? So we're sort of middle of the country east today. But we even are treating patients from Arizona that are making their way to some of the institutions. So if there's a need, we will certainly address that.
John, is there any, like, the location of severing the nerve, does that matter with respect to prevalence of phantom limb pain?
Well, so for instance, whether you have a below knee amputation or above knee, it doesn't seem to differentiate.
Okay.
And we've put the device in both situations with success. So it can be either. The other thing Kym was asking is, does it affect the motor function? Well, you don't have a lot of motor function with a below
30 seconds.
Where the sciatic nerve is going. Most of that function is handled by the femoral nerve, which is what your quadriceps, that's the front of the thigh. And then the back of the upper thigh is all handled by the nerve that's still intact. So the only thing we're interrupting is that very distal sciatic nerve transmission. So it doesn't affect the more proximal hip function.
And then what about if you disarticulate?
You can't do it with a disarticulation because you have to have access to a sciatic nerve.
1220 KDOW.
Yeah.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Well, everybody, we're rounding third. It's a beautiful Saturday here in Florida, and baseball season is upon us. So that's a great analogy. So we've only got about 4 minutes left, right? David, what's the insurance landscape and coverage like? Are people, is this being fought tooth and nail, or are insurance companies buying into this?
Yeah, insurance companies are always a bit of a stumbling block when it comes to new technologies, but we're in a really unique position. We have coverage from Medicare. We also have coverage from most of the commercial payers. So we're in a really good position from a coverage standpoint. We will always focus on improving that coverage over time, but out of the gate, we're in good shape.
What is really the balance? I mean, I'm sure it depends on the insurance, but we have a lot of patients that can't afford general Medicare supplements. So they're on Medicare Advantage plans. And we have the biggest issue when it comes to vascular treatments with delays, pre-authorizations, denials of care the first time around. What is your experience there?
Yeah, Medicare. So for just straight Medicare patients, no pre-auth needed and good coverage. For Medicare Advantage plans, depends on the geography. The majority of Medicare Advantage plans we haven't had an issue with. Some have gone to a couple of different appeals, and those have also been successful.
Oh, fantastic. And Dr. Eidt, so talk about just a couple of your success stories. Would love to hear.
Yeah, I noticed there was a question in the chat. Is sort of how big is the device? I have this little blue thing in my hand. That's about the
There it
size
is.
Device. It's similar in size to that. So again, like a old Zippo lighter, it's not heavy or really obtrusive. I wanted to tell you about the very first patient we implanted. It was a young woman in her late 30s, had a traumatic amputation. She worked as a technician, quite a savvy and personable young lady. We put this device in, and she came back and said, I hadn't slept for weeks before this device was turned on. And she said it totally changed the quality of her life. Turned out about a year or so later, the device actually malfunctioned where the electrode, where the wire kind of plugs into the device, it kind of fractured. And we offered her, said, it's not working. What do you want to do? We can replace it or whatever. She said, you must replace it. She said, I can't live without this device. And it was a very dramatic and heartwarming sort of story when you have this ability to really change someone's life. Now, I will say not everyone had that kind of response. That is, as with any bell curve biologic response, some people get more results than others, but these dramatic, life-saving, life-altering changes can be very dramatic and gratifying to us as clinicians.
So what I think I'm hearing, which I will give a lot of people hope and confidence, is simply that if something happens with the device, you can reimplant, you can put in another one. Do you remove the previous device? Is it possible to remove it?
Yes.
Or does it get pretty well embedded?
In fact, no, we've taken out a couple, and they are removable, and you can replace it. It doesn't do any damage to the nerve. And you can put it back in the same location. So it is replaceable if need be. Yes, it is. The short answer is yes, it can be removed. It can be replaced.
And so where can patients go who might be listening or know somebody that has some phantom limb pain? Just go to your website, or is there a specific location?
Yeah, neurosmedical.com. So they'll find all the information on the website regarding the technology, how it's used, patient stories, testimonials, and a way to contact us for more information.
Yes, and if anyone wants to call the Leg Saver hotline for the Global PAD Association, 1-833-PAD-LEGS. I'll talk with David Veino and his team over at Neuros Medical and see if we can get a list of those doctors that are in fact using it. And if you call us and you have that phantom pain and you need a solution, we'll try and help you find it. And we can even help with transportation to get you there if you need it. Thanks everyone for joining us. Really appreciate you. Thank you, Dr. Eidt over at Baylor in Dallas. Thank you for spending your Saturday. Thank you, David Veino and Neuros Medical. And of course, thank you. Big shout out to my co-host, Dr. John Phillips.
Happy Easter, everybody.